started. Hi, everyone. I'm Jack Cush with Rheum Now, and welcome to Tuesday Night Rheumatology. This week, we'll be discussing two seminal articles on adult Still's disease. I'm going to be joined by two friends. Michael, Bella, turn on your cameras. I'm joined by Bella Mehta and Michael Weisman, and we're going to go over what we think is the two articles that you need to look at and read to understand this particular disorder. Everyone's got an opinion. There are a lot of things written about the disorder, but I was pleased when Michael said, Michael, tell everyone what you told me on Saturday about the Bywaters paper.
It's the only paper you need to read in all of rheumatology. Read that paper, you're done.
Yeah.
That's it. That's all you need to read. It's got
really,
everything in it. It's like the movie Miracle on 34th Street. You know, you see that movie, the original movie with Edmund Gwenn, who played Santa Claus. And you see that movie, that's all you need to know about business. Okay.
It's amazing how articles back then, which could only really do descriptive rheumatology, and were so accurate in what they describe. So we'll introduce ourselves and then get right into this. I'm Jack Cush in Dallas, Texas. Bella?
Hi, I'm Bella Mehta from New York. I see a lot of Still's disease patients.
And Michael?
Hi, I'm Michael Weisman from Los Angeles.
Okay, folks, let's get into this particular presentation. I think you're going to find this really quite interesting. Okay, here we go. All right, so Michael, Bella, you can see that great screen and introduction. Okay, yeah. So I'm going to really present these two articles and ask for input from our Still's experts and some historical perspective on this topic. So, you know, the Still's disease begins in the turn of the century with George F. Still describing 22 patients, kids, with a form of arthritis. Not all of them had the systemic disease that gets the name Still's disease. They really had JRA, JIA, and a subset of them had some systemic features. Not well described were the rash and the fever, but there was arthritis, and then there was splenomegaly and anemia and lymphadenopathy and things like that. But this goes back to even a few years before that, and articles in Lancet talking about the systemic and febrile presentation of rheumatoid arthritis. It wasn't until 1933 that Boldero in the Scandinavian Journal of Rheumatology, I think it was, oh, actually, that's Otto Moltke in 33, did Still's disease in adults, and Boldero described the Still's rash. In 1943, the French literature talks about the Whistler-Fanconi syndrome or subsepsis hyperallergica, which is Still's disease. In 1956, Bywaters and Isdale described the rash of JRA or Still's. But the two articles we're talking about today are Bywaters in 1971, Annals of Rheumatic Disease, describing 14 women with this condition. And then 2 years later, the group from Shelley Wolf, authored by Joseph Bujak in the journal Medicine, described 10 males with Still's disease. There are other really important papers. Wallace Christie and Tom Metzger describing a 50% chance of carpal ankylosis in Still's disease. John Goldman in Atlanta was one of the first people to actually describe his cohort, but he had criteria for the diagnosis, so that's notable. And then John Esdale in Vancouver did a really important case series, 6 cases in American Journal of Medicine, but he looked at the literature and sort of put it all together and talked about the liver disease. Anyway, like Michael said, if you read those first two articles, 71, 73, you've really got it down. So Eric Bywaters, I was lucky enough to have met when I was a fellow, and Michael's going to give us some of his perspective on Bywaters, who he knew, but he had been working on this issue for a while. If you read the paper, they talk about a lot of the kids that people hospitalized in Taplow and Hammersmith in the UK that were different from seropositive RAs. They were younger, they were milder, they were seronegative. They had other features and that they later said were akin to JRA. Yes, many of them went on to develop other conditions, but they had this cohort that they followed and collected over a 20-year period. So they went on to say that Still's disease does occur in the adults, And again, you should know that back in the 50s and maybe 60s before, Still's disease could mean JRA or JIA across the board, all the subsets. It's only been really since about the time of Bywaters, the 70s and 80s, that we've adopted the systemic variant to be called or be named after George F. Still. So they talked about their 14 patients that were collected. You know, a bunch of them had longstanding disease, and over this 20-year period, when seen in Hammersmith and Taplow, 14 out of 680 had this condition that we call Still's disease. So in leading up to this, I talked to Michael, I talked to a lot of people, Tony Fauci, Peter Lipsky, and I got this email from Art Weinstein. Art is at Georgetown, and he's semi-retired. He said in 1971, he was in his second year as an honorary registrar at the Hammersmith Hospital. One day he was discussing some patients with Eric Bywaters, one of his mentors, and he pulled out his newly published article in Annals of Rheumatic Disease on adult stills. It reminded me of a case he had seen in Toronto a few years earlier when a young woman with fever, leukocytosis, high sed rate, LFTs, a rash, arthralgias, back pain, you know, all the workup was negative and whatnot. And he realized at that point that was probably Still's disease, and he missed it. Of course, the patient did well on steroids, later Defervest and whatnot. He said ever since he's been looking for these amongst his FUO patients. When I asked John Esdale about this, he said the great thing about Still's disease is the diagnosis rests solely on clinical findings and a few simple lab tests. You don't need, you know, a lot of expensive testing. And he believes that this is something that rheumatologists should confirm as a diagnosis. Michael, you responded to Art Weinstein's email. Tell us your own story.
Well, in 1971, which was the beginning of my 2-year fellowship with Nate Zweifler, and I don't know if anybody on this call remembers Nate, but they should. We call him Nate the Great. He was an amazing character. And he had a Thursday night clinic. He said, because at Georgetown, where he was before he came to UCSD, patients needed to work during the day and they needed to go to the doctor in the evening. So we had a Thursday night clinic, and this woman, I remember Sylvia F. was her name. She was around 42 years old. She came in with fever and rash and large joint polyarthritis, and this had been going on for a number of years. And we got x-rays of her wrists and hands, and sure enough, it showed widespread joint space narrowing and some carpal ankylosis. And Nate told me about this paper that had just come out in Annals of Rheumatic Diseases. And there was Eric Bywaters' paper that described her to a T. Now, the other thing Nate did was he invited Eric Bywaters to come and spend time with us. And he did. Eric came, and he was visiting professor at UCSD for most of a week. And we got to know him very well. What an amazing individual he was. And as I don't think people on the call really appreciate, is that the way things were done in England in those days was that you as a rheumatologist followed your patients all the way from beginning to death, and you actually performed an autopsy on your patients. So you became an amateur pathologist as well as a diagnostician. So you saw the patient all the way from the beginning to the end. So when you read Eric Bywaters' papers, there's always pathology. You remember he described the pathology of rheumatoid nodules and rheumatoid vasculitis because he was the consummate physician from beginning to end. There are lots of stories. We could take up the whole hour and talk about Eric Bywaters, and we don't want to do that because everybody's missing the baseball all-star game. So we have to kind of cut this discussion a little bit short, Jack, and just say that maybe another time we could talk about the impact of Eric Bywaters on rheumatology. Yeah. One other comment, though, about his paper is that not only did he describe adult stills, but he also described the difference between that and seropositive rheumatoid arthritis. Mm-hmm. And he was one of the few people that actually pulled out of rheumatoid arthritis all of what we call seronegative spondyloarthritis today. And he described that as completely distinct from rheumatoid arthritis. Now, that was not accepted in the United States even up to 1971. And that was because of an individual at the Massachusetts General Hospital who was the consummate rheumatologist and trained many people in the United States. And he refused to accept the difference between rheumatoid arthritis and the seronegative spondyloarthritis individuals. But Eric Bywaters made it very clear in this paper in 1971 that these were distinct clinical entities.
Yeah, and very important historically for the evolution. So here's one of the first figures in the paper, and I want the audience not to take it all in, but look at specific columns. Look at the third column, age of onset. The age here ranges, they're in their 20s for the most part, and ranges from a young of 17 to the oldest of 35. That's Still's disease in the adult. You know, when you start making diagnoses at 50 and 63 and whatnot, you're out on a limb if you ask me. Look at the joints. This is a little bit different than what was said in the Bujak paper, where they said there wasn't so much arthritis, but there was a fair amount of joint involvement, although Bywaters did call this fleeting, and only in a few cases was it chronic and progressive. And you can see that in the next column next to it, where they're talking about the number who develop either carpal involvement or erosive disease and whatnot. And then look at the far right column with other. You can see all the other things that we know to be true in this condition: splenomegaly, hepatomegaly, pericarditis, other forms of serositis. You know, there's some strange things in here. There's neck involvement. There's TB of the lung or TB of the spine. One person goes on to arthroplasty. A few patients lose hair. So let's get into that a little bit. But I think that this really shows you, even back here in the 50s and 60s, when these patients were collected, they really well characterized the syndrome.
I think so. I think he's characterized the syndrome well, but I wanted to say the comment on like, these are younger patients. There's definitely another peak of Still's disease, which we see. There's a later, after 50s also that you see some patients.
Let's get back to that, because I think that that's a really important point. And Bella's perspective on this is wise, because she studied this. She studied, and actually has, the codes and, population-based data to back that up. And so I think it's something we should discuss towards the end. These are the key features from this article. The presentation age was 17 to 35. They said the rash would appear and disappear and then reappear, often with fevers and often at 6 p.m. So I think is an important part of the disease. It's a quotidian disease with a circadian pattern to fever. It's really uncommon to have fever early in the morning. These are late day, late at night fevers. Along friction lines, the feature of not dermatographism and what's the other one? Isomorphic lesions. I'm blanking on the term. But again, you can get this along creases and bra straps and whatnot. Rarely itchy, but some people do get urticaria. And it's a sort of a static set of lesions or maculopapular eruptions that come and go. It doesn't spread like rheumatic fever. Again, think of 1971. There's a lot of references to what was big on their minds at that time, which was rheumatic fever. The fever, they said, is dramatic. It can be confused with sepsis. They said it either had a quotidian or a remittent pattern. Quotidian meaning fever that goes back to baseline. In the same day, remittent stays with a high baseline and then spikes up to 102 or higher. They said that the joint involvement, it was peripheral, fleeting, occasionally chronic or erosive, was both large and small joints. They talked about hip involvement and DIP involvement. And again, they did show 3 patients with carpal involvement, 2 with cervical involvement. Again, at the time, there was a lot of discussion about cervical and or SI involvement in these kind of conditions. And that goes to Dr. Weisman's point about distinguishing this from the other patients who went on to develop seronegative spondyloarthritis. Hair fall, not uncommon with high fevers, pericarditis, pleuritis, splenomegaly. And at the time, they were using Rose-Waller tests to look for rheumatoid factor, or that then version of rheumatoid factor, and it was negative in 13 out of the 14 patients. So those are the key features. Anyone want to comment on that?
Jack, we used to have 2 other key features. One was that the house staff would always miss the rash because they'd be going home at the end of the afternoon when the rash, would appear. So that was one of the features. And the other feature was if the infectious disease doctors absolutely refused to accept the fact that this was not an infection, you knew that was a criteria for the diagnosis of adult stills.
Yeah, those both great points because, usually when the house staff came back on in the morning, they were not going to have their fever, which meant they were unlikely to have their rash. I think right now, most of our cases of Still's disease come from ID consults. When they're done doing their work, then they're handing it off to you and making your life easier, which is very different, Michael, than what you were doing back in the 70s and 80s when these people came in with horrific stories of workups and evaluations that went on for months and years and specialty services and lymphangiograms and laparotomies. And when I did the review at University of Pittsburgh of their 23 patients, I was shocked at the stories that led to the diagnosis. Was that your experience?
Of course. And I wonder if Bella had the same experiences I did. We wrote a paper some years ago about sore throat that occurred in adult stills, which was really very common. And that always got confused with rheumatic fever. And these patients always got antibiotics. So that whole scenario also delayed patients getting a proper diagnosis. Bella, did you see that?
I think even right now, sometimes I see patients who have been referred from specialist to specialist, hematology, bone marrow biopsies, lots of crazy workup before a simple ferritin or a simple, referral is done. Like there are times I've had patients who have not got diagnosis for 2 years. Average time to diagnosis, even in some studies, is like 3 or 4 months, which is still something in this day and age with everything available.
Yeah. So
and
that
the
was
other thing that was characteristic was if you just ask one simple question, which is, did the fever come down to normal within a 24-hour period? So all you needed to do was to look at the fever chart. And if it came down to normal every 24 hours, there are not that many infectious diseases that would do that.
Right.
Or other causes of fever, and it doesn't happen usually with lupus. So, that was a real important clue. In the old days when you have these written fever charts.
I want to follow up on what Michael and Bella said. Michael representing what happened in the 70s and 80s, where it was the rule that they had horrific workups and lengthy periods without a diagnosis. And Bella points out that it still happens today. But today, the big challenge is patients with 2 weeks or 2 months of fever, and we're being asked to make the diagnosis, and that makes it more challenging. That's more likely these days. Here are some figures from the paper. Let me see if I have that. That's the original fever. I want to point out that obviously that spiking fever that goes down to baseline normal and then up above 103, and again really should be above 102 to be considered the spiking fever of Still's. But notice that when they add in salicylate in high doses, the fever pattern changes. If you add in a steroid in any dose, the fever pattern will change. This patient had a rub, and then again, a recurrence that one way when the patient was treated. But back then, that's all they had was aspirin. This was one of their cases in the middle. You're looking at carpal ankylosis, and it's not fully ankylosed. Early ankylosis in between the capitate and the second, maybe third base of the metacarpal. But this was described by Metzger and Christie, where it's pericapitate distribution of joint space loss that leads to carpal ankylosis. So the capitate fuses to the metacarpals, fuses to the scaphoid or lunate or to the hamate laterally. Again, this is a very typical pattern. And then on the right, I think what you're seeing that's important and instructive is active disease and then disease-free intervals. And that is a typical feature of Still's disease. Now, not every patient has the so-called polycyclic disease, but that is typical of the disorder. Any comment from my discussants?
Well, I mean, salicylate, I've never used salicylate in these sort of doses. I mean, again, I'm from a different era of rheumatology. So just looking at, how they were treating it, I was like, there's liver toxicities and all of that they're trying to monitor. And they're saying, hey, we did a good job with liver toxicities with the salicylate levels. I have no experience of this.
Well,
it's interesting.
Bella, you know that in those days, at least in the 60s, or maybe in the 50s, all we had was bed rest and salicylates until your ears rang. And then you cut back on the dose. And that was the standard treatment for all forms of rheumatoid arthritis. Really until of course the discovery of cortisone and how everything got turned around in the early 50s, when then steroids were becoming the baseline treatment for
the goal of therapy was ring in the ears, but really blood levels where you were trying to get 25 to 30 milligrams per ml as a dose, and that was your therapeutic range. We'll get into that in the next paper as well. The outcomes are pretty typical. 2 out of 14 had progressive crippling arthritis. 1 required bilateral hip replacement. And they were important to clear to say that everybody became normal and were leading a full life, and a few got married and are having kids. And that most who had joint involvement, which was seen in most, it was transient and sometimes remittent. And he said that sometimes what was the most troublesome symptom to manage was the malaise, fever, and rash that sometimes persisted in patients. And then lastly, the complications of steroid use. When steroids became available and were being used, that psychiatric disturbance was not an uncommon story. So again, some very key features here, including the prospect of normalcy. You know, no one should really die from Still's disease if they don't get MAS or they don't get steroid toxicity. Those are the 2 main ways that patients will die with steroids. And when I say steroid toxicity, get the consequences of chronic high-dose steroid use. So the next paper was by Joseph Bujak, and I did reach out to Tony Fauci and Peter Lipsky, because they were both at the NIH at the time that Shelley Wolf was there. Shelley Wolf is a famous individual known for his work in fever. He's an infectious disease person, and led to a lot of great careers. And he was a senior author on this paper. Both Fauci and Lipsky said that Bujak was assigned this project of reviewing all these cases and putting it together into a report. But you know, this group that was working on fever became very important in description of Wegener's and FMF and autoinflammatory conditions, and later the interferonopathies, and basically led to the current, you know, autoinflammatory clinic that's a big deal at the NIH, run by Rafaela Goldbach-Mansky and Dan Kastner. So again, there's a real history here that's important. Neither Fauci or Lipsky knew what happened to Joe Bujak. I assume he, like many of us, went into practice, but again, he's given the credit for this particular paper, which was also seminal. Different from the first one in that this was the first one was 14 women. This was 10 men. And that was one of the early arguments between those who were talking about this condition. Is this a disease of men or is this a disease of women? Clearly,
well, Jack, you know, this points out
what's
something really interesting about the kind of patients that get referred to the NIH. Okay, they're not the same as the patients that get referred to you in your practice or to see Bella in New York. This is a different group of patients. If you think of Sjogren's and the way Sjogren's was described at the NIH in the 1950s and 60s, remember, you know, 20% of them had lymphomas. I mean, this was a very different group of patients. So I think you have to keep that in mind when you look at these NIH clinical reports from the clinical group there, which brings me to ask Bella the question, you know, this business about this being a benign disease and patients doing well, you know, with therapy, that's not been my experience. Bella, what's your experience with this?
I would want to say, like, there's a percent who do very well, like maybe a good percent, 50%. But there's another 50% that are going into complications, MAS on and off. And it's not like, oh, you get a diagnosis, you get treated and you're fine. There's a lot more there's a lot of watching of these patients to do, a lot of monitoring.
What about the material now that we're learning from our pediatric colleagues that there are delayed hypersensitivity reactions So IL-1, anti-IL-1 and anti-IL-6 inhibitors that have a genetic predisposition that may occur in these patients, and they'll get severe lung disease. In fact, they do very badly when they get these hypersensitivity reactions to these drugs. What's been your experience, Bella?
I think there's another group of patients who have mast cell activation with stills that's diagnosed by allergists and whatnot. And sometimes these patients are totally biologic naive and they're still getting these crazy allergic reactions or hypersensitivity reactions. So I'm not quite sure what the exact mechanism is. There's definitely much more patients that I see with these sort of reactions now, but no, I haven't seen much with lung sort of involvement because of hypersensitivity.
The story on lung disease is that certainly that 40% of patients will have, pleuritis and 20% will have pneumonitis, but there is a subset, and it's been written about back into the 80s of chronic lung disease occurring in Still's disease. Now, is that just casual bystander effects, people developing COPD or ILD for other reasons, or is the ILD related to the Still's inflammation? There are some who believe that pulmonary hypertension occurs in Still's disease, sometimes as a consequence of cytokine inhibition, mainly IL-1 inhibition. But there are a lot of unresolved issues, including the one that Michael brings up from the Stanford group that's basically showed a DRESS syndrome that had a particular HLA association and was associated with eosinophilia and whatnot. Now, again, that kind of work needs more effort and needs to be reproduced. But I think, and it's really all the buzz in the pediatric literature in Still's that maybe there's a really bad lung variant out there that can be another reason why these people may do poorly. But without that, and without MAS, the only reason a patient should do poorly was from chronic arthritis, which the numbers historically have been about 25%, usually not more than 30%, that would develop a seronegative polyarthritis that would look just like RA and behave like seronegative RA, which generally means pretty severe.
But it's important Jack, to maybe put a link in your program to Vivian Saper's article in Annals of Rheumatic Diseases, where she described the subset of patients with Still's developing DRESS syndrome to anakinra, canakinumab, rilonacept, and tocilizumab. These patients did very poorly, and they almost all had this HLA-DRB115 alleles. And this is a striking finding and very important in terms of management of these patients. Maybe give everybody a link to that Annals paper. I think it was published in the fall of 2021. Mm-hmm. It's a very important paper. Everyone should.
I mean, just another argument. Even in the Bujak paper, I think there were 3 patients who had eosinophilia. So these were, at that point, they were not getting exposed to any of this.
Right.
Yeah, it's been described, the eosinophilia. I did, for the group, I did give you the 2 citations where you can download both the Bujak and the Bywaters article, and then I'll post on Room Now this article that Dr. Weisman is referring to. I think it's another important. We did cover it in Room Now, but it probably goes back about a year now that came out. So, but we'll post that up again for people to see. So let's get into the particulars of the Bujak article. They did, as you can see, it was started in 1973, and as Michael said, it's a special population. So the NIH was following about 200 FUO patients. And of their 210 fit this particular profile of JRA with systemic features. They called it, again, JRA back then, or Still's disease. They were all male. Half of them had an onset during childhood with a mean onset at age 6.8 years. The other half had an onset at 21 years of age. And you can look at the table on the right, about the features that are being displayed here, right? How many had high fevers? All of them had high fevers. Adenopathy and splenomegaly in most. Pneumonitis, so very high compared to other series of 60%. Pericarditis, that's about right. Sore throat, that's about the right number. And John Esdale pointed out to me, this is probably one of the first articles to really highlight the sore throat as a distinguishing feature. And of course, that's a prodromal. It's at the onset of disease when they're having fever and the onset that they will often present with sore throat, and that will abate as they get more and more into the condition. And so you see, they all had polyarthralgias, but true arthritis that lasted was only in 5 out of the 10. On the bottom left is a table they had looking at asymptomatic intervals in those who had recurrent disease. And again, I think that's an important feature of this disease, that it is a condition that, and I don't know the right answer. I've always said, when people say, how long is this going to last? I say 8 months to 8 years, and I think I'm close, and that's just based on looking at lots of papers. But I think if it lasted 3 months, I don't know if that really would meet criteria for the diagnosis. But you can see that many patients have long disease-free intervals. The longest one I've seen in the literature was over 40 years. So that is a part and parcel of the condition.
It's interesting that all of what was described as a stress reaction to these biologic treatments with this haplotype, it all occurred in little bits and pieces, even before, as Bella pointed out, even before we had the biologic drugs. Right. So, and that's occur in a lot of our diseases. So that the genetic predisposition may in fact have more to do with the severity of the reaction and the severity of the disease rather than actually the occurrence itself. And so that's why the argument can be made to do genetic testing in this population. But it's an interesting part of it, and I'm glad Bella pointed that out. All these things were seen even before we had biologic drugs. But now with the biologic drugs, they're seen to be very severe when they occur and life-threatening, which was not the case, before biologic.
So again, the 10 males who they presented, and they give some case reports that you can read their narratives. All of them had a quotidian fever. 9 out of the 10 had a fever greater than 105 as a peak fever. Double quotidian was seen in 3 out of 10, and 2 out of 10 had a remittent or high baseline pattern. Rash was evanescent in 7. Half of them occurred with fevers. And like all the other biopsies that were seen, whether it's the skin biopsy, synovial biopsy, liver biopsies, it's nonspecific inflammation. There's really nothing that ever has panned out biopsy-wise in the diagnosis. Same can be said for the lymphadenopathy, which is generally generalized, but in their 7 patients, 3 were generalized, 2 had bilateral inguinal, 1 was cervical, 1 was axillary, 1 had like mesenteric on laparotomy, and the biopsies proved negative. Splenomegaly, pericarditis, pleuritis, pneumonitis, hepatomegaly, LFTs, and again, biopsy of the liver showed periportal inflammation. And then again, the sore throat was a new feature seen in 7 out of 10 patients at the time of their febrile diagnosis. Has sore throat been important for you, Michael and Bella, in making the diagnosis?
We wrote a paper on it, Jack, with Kathy Nguyen, and we compared it to lupus patients, and lupus patients also get sore throats. Oh. But it was much more common in the adult stills. So we paid a lot of attention to it.
So it doesn't happen in kids, right? Kids with systemic disease.
Yes.
I think that's interesting to say the least.
The other part of this, of course, is that NIH doctors were fever doctors. They were interested in FUO.
Well, Shelley Wolf, yeah.
Yeah, so they maximized the systemic features of the disease and minimized the articular ones. Whereas Bywaters, that was an arthritis hospital. Taplow was an arthritis hospital that was started to treat kids with rheumatic fever. And after the war, of course, rheumatic fever went away to some extent, and they were left with juvenile rheumatoid arthritis as a group that came. So the focus was on arthritis. So right. Depending on your ascertainment bias going in, your cohort is going to reflect that.
The other aspect of this that feeds into what you just said, Michael, is that the triad of Still's disease, the quotidian fever, the evanescent rash, and the polyarthritis, of those polyarthritis, first off, they are seldom all 3 present at diagnosis and presentation. And of those, the arthritis may be the one that comes up last and may take some time to really take hold. But there is no set pattern. There are patients who present with arthritis and get the rash, second year in. There's really no specific sequence here that must happen to cinch the diagnosis.
And the rash looks different in different populations.
Yeah.
I'm in New York. I see there's a diverse group of people. The rash can look very, very different in certain populations. It doesn't look evanescent and, the typical describing things. I think I go by like there's presence of some sort of a rash which comes with fever mostly, and then you just have to go by it.
So if it's faint and salmon pink, it may be a lot harder to see in someone who's Hispanic or African American, and the fact that it comes and goes makes it even harder. When I met Eric Bywaters, I was just accepted for the fellowship program in Dallas, and he was at a program there, and I was so excited. I cornered him. I'm sure I was a stalker back then, and I asked him, "Listen, how do you make this diagnosis? It's a tough diagnosis. What can you hang your hat on?" And he said, "The rash." And he went on to tell me about the importance of the rash. Fast forward like 15 years, I'm at the American Academy of Dermatology meeting. I'm giving a stills lecture to about 2,000 dermatologists. And I say the most distinctive part of the rash is the salmon pink evanescent rash. They all booed me. They said, "Oh my God, it's a morbilliform viral exanthem rash, a knucklehead." And they're right. It is not truly specific, but it is different than a lupus rash or a leukocytoclastic rash or whatever. So anyway, I was great to be humbled by 2,000 dermatologists.
You should have learned a big lesson to not talk about a rash to a group of dermatologists.
Exactly.
I mean, talk about arthritis, something they don't know anything about.
Right.
But leave the skin alone.
But
dermatologists refer a lot of patients to us.
That's true.
For stills, they see that there's something different. Maybe go to rheumatology. So that's a good referral point.
Yeah.
So the joint features here are pretty distinctive. Everybody has arthralgias and myalgias at some point. They felt at the NIH that it had to be large joints and not much small joints, but Bywaters said quite differently. And I think it is both large and small joints. They said it was transient. Only a few had carpal disease, but SI and TMJ was not typical. Anybody want to add anything? I think that cervical ankylosis Bywaters wrote about, and I've seen tarsal ankylosis in the Pittsburgh series that may also be akin to wrist ankylosis or carpal ankylosis. But other than that, I don't think, and there's a few cases with myositis, and I think that there could be some confusion and overlap there, but they're very few.
Well, you have to separate out what are the acute diagnostic features versus the chronic sequelae of having the disease for a while, Jack. You can't. But I wanted to find out from Bella, how often do you see these patients? I mean, you come from a center where a lot of difficult cases are going to get referred, right? Special surgery, because it's special, right? So you're going to get these cases. How many per year will you, as a rheumatologist specialist in this area, be asked to see? What number would you come up with?
Maybe 2-3 years ago, I was getting like 2 or 3 patients, 4 patients every quarter, I want to say. But suddenly I see a surge of referrals for stills. I want to say every 2 weeks, I'm seeing a new patient with stills right now, which is for stills, it's a lot. Like I have a cohort, I want to say of 40 or 50 patients now. So and mostly because nobody, peripherally, there's people who are like, okay, there's somebody who can manage these patients and they just send them in. But I still feel that I don't see a whole lot of ankylosis now. It's like RA, right? Back in the day, there was much more joint damage before diagnosis or, before treatment. Now I feel like there is erosions, but not like fully ankylosis that I see.
So that's quite a number of patients you're seeing. Well,
there's been a surge for sure.
What do you think that's due to?
I think it's due to Bella's hard work is what that's due to, because the numbers are very clear. At a teaching hospital like Cedars-Sinai in LA, the most you're going to see is 2 cases a year at Cedars-Sinai.
That's right.
That's a population-based sort of numbers here. So, but Bella's been working hard in this area. She's known by a number of people in New York and the metropolitan area. So she's lucky and she gets to see that. And that's why her perspective is so important.
And I mean, patients drive into New York City from like Connecticut, New Jersey, like Massachusetts. So it's not just one state. There's like a lot of people who would seek for somebody specially for stills.
Right. Lab-wise, they become anemic, and their anemia, this is what I observed. Their anemia can drop. They can drop a hematocrit from 38 to 28 in a matter of 2 weeks. And it's not hemodilution. And you know, when the hematocrit drops, you know what also drops? Is their weight and their albumins. They all parallel together. And it's due to excessive cytokine production, mainly IL-1 would be my guess, but it could be IL-18, it could be IL-6, a number of other mediators, but it is rapid. They noticed a mean peak leukocytosis of 23,000. That's higher than my experience, which is more like 15 to 18,000, but their range was 5 to 36,000, and 80% of patients had a WBC greater than 18,000. The SED rate had a mean peak of 86 with a range up to 125, and they were all seronegative. Any of you have a tidbit on labs that you want to impart on the audience?
You know, the IL-18 levels or something, that's not very easily available. Cytokine panels, even standard cytokine panels, it's difficult. So you still got to go through this and ferritin and the regular labs to assess treatment options.
Yeah. Haven't you seen a leukocytosis sometimes greater than 50,000?
I've seen 3.
Yeah.
3, but not many. If you're seeing white counts greater than 50,000, you need to be thinking about malignancy and other causes more so than stills, but it does occur. I mean,
that's what's striking.
Yeah, that's really true. I want to impart on the audience that ferritin levels, and Bella, you can correct me, but ferritin levels, extreme ferritin levels, you know, greater than 2,000, probably less than 50% of patients with stills. We have a love of ferritin, which is probably inappropriate if you ask me, whereas SED rate and CRP are elevated in over 90% of individuals. What I did in reviewing the 21 patients in Pittsburgh, I showed that in their patients, 50% had a SED rate greater than 90 and 90% had a SED rate greater than 50. And that was about what you were seeing as far as acute phase reactants.
True. So, I mean, ferritin helps you sometimes, but not always. And sometimes people are like, oh, the ferritin is normal, the patient doesn't have stills. So that's something that I really would caution against. You know, if everything still points out, you need to think about it.
Something that most people don't know about, and I would encourage people to use, the best biomarker that is commercially available that you can use right now, I believe, is aldolase. Aldolase is going to be elevated in patients who have extreme systemic inflammatory symptomatology. It indicates IL-1 responsiveness. If you check a CPK, the CPK is normal, but the aldolase is going to be like 12 to 35, and it will parallel disease. And it's a very good biomarker. I learned this from the pediatric rheumatologist in Dallas, which, you know, that all started with Chester Fink many, many years ago, and then Lynn Pinero and Virginia Pasquale and others. So,
and where else, Jack, you see aldolase out of proportion to CPK? What else does that tell you?
I don't know. I'm going to ask the former chief of rheumatology at Cedars-Sinai. Are you going to tell me about inclusion body myositis or something?
Sure,
like that?
You've got to look for other kind of weird things that occur under those circumstances. Right. Yeah.
Well, aldolase in this case is coming from liver, okay, and not from muscle is most likely the cause. We don't know that for certain, but obviously you can get aldolase elevated in extreme liver damage and extreme liver disease. So that would be my answer to your question, but there may be some other myopathies where aldolase may outdo the CPK.
So let me ask Bella, what is your therapeutic approach to these?
Well, let's
cases?
just look at look at what they did. Again, Bella doesn't know about what happened in the dark ages when we only had aspirin and indomethacin. At the NIH, it was aspirin, TID, QID to achieve really high levels, or indomethacin, 200 milligrams a day. But as you can see on the bottom, they had cases of aspirin hepatitis, aspirin GI-induced ulcers, but that's all they had. They used steroids, but they didn't describe it a lot. At the NIH, they were very much into alternate day steroids back then. And that was their guidance, 60 to 120 milligrams every day or every other day. But obviously it's different now.
I mean, I still know some people who do every other day steroids, but I don't know the rationale to be fair.
Bella, do you use an IL-1 inhibitor like anakinra as a diagnostic test?
Sometimes, yes. Because
Problem is, with IL-1 inhibition will make flu fever go away, make the fever of lymphoma go away. I have those cases.
By that time, hopefully you've ruled out.
Yeah, you would think, but it's not. It is a nice empiric maneuver, but to say it's diagnostic might be overreaching, in my opinion.
All right, that's why I asked the question. Somebody who's on the ground, seeing this vast number of patients, right? So, what is your initial approach, Bella? Other than, I mean,
it
obviously,
depends.
make
I think
the diagnosis.
first thing is still steroids. I mean, if they're steroid responsive versus not, and then sometimes you try if you're sure, you do a long acting IL-1. Otherwise, you try a short acting, see how things go. And again, it's a lot of it is insurance driven, at least in the outpatient world. But one question, I mean, aspirin. So do you do aspirin levels every day when you give these sort of doses?
Not uncommon back then. It was more not every day, but more like 2 times or 3 times a week. And then once you achieved over 25, and again, if you look at the early literature, as I did when I was a resident, and looking at these cases in the 70s and 80s, 50% of patients responded to anti-inflammatory therapy with NSAIDs or aspirin alone.
Yeah, I mean, even in this paper, they are saying that like 4 of them went into what we call now as remission, didn't have any symptoms just on these things.
Right.
I don't know. I mean, most patients have already tried NSAIDs quite a lot before they come to see.
But this is high dose. This is really high dose. Trying a few Advil is not going to make the difference, or 1,000 of naproxen, I think, is below what this is showing. And I think it goes to the same point that I think you're right to say this doesn't make any sense to me. What doesn't make any sense to me is trying prednisone at 10, 20, 30 milligrams. I mean, these people need 1 milligram, 2 milligrams per kilogram to control systemic disease. Much less for arthritis, but for systemic disease, they need high doses.
All right, but that can't last more than a month. So when you're talking about persistent treatment over 3 to 6 months, Bella, what's your approach?
To be fair, I do try methotrexate in arthritis prominent patients, and it does help a few patients. And I still try. It's easier, like daily IL-1. It has rashes, it has problems. The patient's calling you every day. So I try methotrexate in like sort of milder cases, but if patients are like spiking fevers every day and not doing well, I try anakinra, or if I'm sure, I directly try like long-acting IL-1 agents.
And what's the role for IL-6 inhibition?
I think my preference is IL-1. Okay. I go to IL-6 when I am out of options, or there's some other reason that drives me, like arthritis is not getting controlled.
Have you seen these very severe, eosinophilic drug reactions when you use these drugs?
I haven't, and I have used quite a bit of these drugs. I think, again, like it's the selection bias too in these papers, like these centers, whoever, I mean, it's so difficult to get like genetic testing of patients, like just in the outpatient regular clinic world. So yes, this is a chance, but I haven't seen any, which is.
Well, it points out something very interesting, because the geneticists in Vivian's paper are telling us that they think that the HLA associations actually are stronger for the most severe drug reactions than they are for the severity of the disease. That is the HLA is telling us more about strength of a drug reaction than it is about the disease itself. And, you go back in years and think about it, there have been HLA associations with gold toxicity, Jack, that came out of Dallas.
But there've been, again, HLA typing has been done on a number of cohorts with Still's disease. And other than HLA-BW35 being associated with, good systemic outcomes and, HLA-DR4 or DR beta 1 alleles being associated with bad arthritis outcomes, nothing really has panned out until this recent report that centers on a very small number of people with tocilizumab related DRESS kind of things. I don't know where this is going to go. I don't think that, let the Stanford
argument is that
work on that.
Do we know enough to do HLA testing as a pre-therapeutic screen?
No.
Okay,
gigantic waste of money.
Just bringing it up. That's
gigantic
all.
Waste of money. I want to remind that the recent guidelines on the management of systemic disease says, yes, steroids is first line, and then go right to IL-1 or IL-6. And you don't have to do a lot in between. It's okay to use DMARDs like methotrexate, but you can, per the guidelines, go right to IL-1 or IL-6. And Michael, I'll answer your question. When would you use IL-6? I think the best way we use IL-6 is when I'm having a problem getting IL-1 approved, and I can call my Stills patient RA and get IL-6 Actemra or Cerullimab approved with the idea I'm treating the arthritis. But that gets into some other issues on dosing that we're going to discuss next week in our journal club. Then I want us to go over a few unanswered questions in the time we have left. Anybody has questions, they can put them in the Q&A box. There is no diagnostic test, imaging, or pathology. The duration of disease is unclear and unvariable. The meaning of the sore throat, we don't know. It's not seen in kids. It is seen in 70% of adults. It's seen in 10% of kids. But is it a portal of infection? Is it lymphoid reactivation from immune activity? Who knows? Again, I don't know about every other day steroids. And then this is what they summarize. So in the end, this is what the syndrome looks like if you compare the first 24 cases reported by Bywaters and Bujak, and they have some differences, but they also have, which may reflect the centers, like way Bywaters did it in England versus the way the NIH and Shelley Wolf did it in the United States. But I think together, this gives you a really good feel for how this condition should be diagnosed.
Okay.
Managed, I don't think you're going to learn a lot about management from these papers, because as Bella has been scratching her head on these slides, who in their right mind is going to use, doses of, 90 to 100 milligrams per kilogram to get those drug levels. It'd be insane to do that, especially as Bella pointed out, there's a high rate of LFT and liver involvement and cases of liver failure in patients who got non-steroidals and aspirin for their systemic disease. So,
well, I think if Bella orders a salicylate level at HSS, they may send her to counseling or something.
All right. Let's look at, I think we have a few questions from the audience. And again, the audience, if you go into the chat, you'll see the citations. Steve Hall mentions that the original Petersdorf and Beeson paper included several who had typical Stills disease. Yes, if you look at FUO series, Stills disease in the adult is the #1 rheumatic cause of FUO in many, many papers, with percentages ranging from as low as like 5% to as high as 12%. Bella, is that your experience in FUO workups?
Sorry, I didn't get that question again.
Are you discovering Stills patients who get hospitalized specifically for FUO and later it's diagnosed as Stills? Is that still a common scenario?
Yeah, I mean, I think most of those patients are MAS patients in the ICU, like very, very sick, having spiking fevers. So those are the inpatients, I would say, which have like a whole lot of FUO workup, and then rheumatology is called. In the outpatient world, I think there's some, not that much.
Right. Steve also mentions that if you ask a patient to take a hot shower, sometimes it can bring the rash out. Not sure what that really proves, but I've read that. I've seen it a few times. I don't know that it's truly helpful and worth people jumping in and out of showers for diagnostic reasons.
Yeah.
And then Christian Duquette says that aldolase has been found to be elevated in eosinophilic fasciitis. That's kind of an interesting point in response to Dr. Weisman's question. So closing comments, Michael?
I think this was great, Jack. I tried to be a little provocative here, specifically asking about the genetics. I think this is a really good discussion. I think Bella's great. I'm really glad she's there seeing those patients, and she's the person I'll call when there's a problem. That's great. And so I think this has really been very interesting, and certainly worth not watching the introduction to the Major League Baseball All-Star game. It's a much better deal here.
Bella, what closing comments do you have?
It's been great learning about stills and the history of stills. There's so many nuances that you don't just get to read. It's more about talking to experienced people like you all. And I think, both of these papers are still so seminal. Like, just reading them even right now can fully describe a Still's disease patient, including histology. Like, they've done synovial biopsies.
Sure.
These are the things that you can teach a medical student who doesn't know any of that. This is like a Still's disease book chapter. That's a paper.
Sure. Bywaters introduced autoinflammatory diseases and told us that they are very different than diseases characterized by antigen antibody complexes. So it was beautiful. And he says, I'm going to discuss it with my friends Muckle and Wells. I thought that
exactly.
was
Yeah. Wasn't that a cool comment?
Yeah. So he knew what he was doing.
Robert Cornett from New Orleans asks, what other diagnoses would be or are often mistaken for Still's disease? Bella, do you have your top few? And what do you do?
I think it's unfortunate, but a lot of patients with Still's disease have like evening fevers, some rashes here and there. They're diagnosed with fibromyalgia for a long period of time sometimes, which is unfortunate. And the patients are miserable for a long time. In terms of I think a lot of patients are treated as RA and maybe they just forget the fever component sometimes, and like the arthritis component is treated as with methotrexate, then rituximab, then Humira, then that is the line, like a typical RA patient that they are treated, and then it takes them a while to get to this diagnosis of Still's, just because they start a line of treatment already.
So again, this is a syndrome. This is a diagnosis of exclusion. I would strongly recommend that anyone considering this diagnosis go and look at the criteria. My criteria, the Yamaguchi criteria, you can go to our new website, stillsnow.com. We have a disease activity calculator and a diagnosis calculator. Check boxes. It'll tell you which criteria you meet between the published criteria that are out there. And that helps you to at least make the right diagnosis in moving forward. And I also want to pitch the idea that this month we're putting out a lot on Still's disease for a good reason. And Bella had a really nice blog yesterday. She wrote about Still's disease as a complicated disorder that has its complications. And I think that's a worthwhile read that you can find on Still's on the front page of our Room Now website today and tomorrow and whatnot. So hope you enjoyed this. We're going to have a presentation, another journal club next week, where we're going to discuss the seminal canakinumab and tocilizumab, the Consider study in canakinumab that led to canakinumab being FDA approved for adult onset Still's, and the Tender trial in tocilizumab in kids with systemic JA that led to that being FDA approved for children with systemic JA. Very interesting articles. I believe we're going to have discussions of Olga Petrina and Hermine Brunner on that journal club. So make sure to tune in next Tuesday night. Tell your friends. This will be on Room Now if you want to share the video or the podcast in the next few days. Okay. Michael, Bella, thanks very much for your time.
Thank you, Jack.
So much.